Good morning, ladies and gentlemen. My name is Giorgio Lambro. I'm a neurology consultant at St Thomas's Hospital, London, UK. Today I'm going to talk to you about the clinical presentation, differential diagnosis and treatment of SUNCT and SUNA. SUNCT is an acronym standing for short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. This acronym implies that the headache attacks have to be associated with both ipsilateral conjunctival injection and lacrimation. However, given that a similar headache phenotype was described to be associated with only one of the common facial autonomic features, the International Headache Society Classification Committee proposed the term of SUNA for those patients. SUNA stands for short-lasting unilateral neuralgiform headache attacks with autonomic symptoms. The diagnostic criteria for SUNCT and SUNA have gone through some changes during the different International Headache Society classification version. Currently, SUNCT and SUNA are classified within the trigeminal autonomic cephalalgias. They have been grouped under the term of short-lasting unilateral neuralgiform headache attacks, and they are characterized by one-sided head pain, normally centered over the trigeminal, one or more of the trigeminal territories, moderate or severe in intensity, with attacks lasting normally between 1 second to 10 minutes, occurring as a single or group of stabs, or sometimes following a serrated pattern. The attacks should be occurring at least once a day when the condition is active. If the pain is associated with ipsilateral conjunctival injection and lacrimation, then the diagnosis of SUNCT should be made. Whereas if the pain is associated with one of the other cranial autonomic features or one of lacrimation and tearing, then a diagnosis of SUNA has to be made. Similarly to the other trigeminal autonomic cephalalgias, SUNA and SUNCT are classified as either chronic or episodic. However, given the rarity of this condition, up until recently the SUNA phenotype wasn't fully detailed in the literature, and it wasn't clear whether SUNCT and SUNA were different disorders or whether they were variants of the same clinical entity. For this reason, we conducted a prospective study describing the phenotype of SUNCT and SUNA in a large group of patients and confronted their clinical characteristics. Our analysis suggested that there were no major clinical differences between SUNCT and SUNA phenotypes, and we therefore propose that the two disorders are placed together under a single diagnostic category. Moreover, our analysis highlighted a few key clinical features that have not been included in the diagnostic criteria, but that could help discriminating SUNCT and SUNA with the other TACs, namely the frequent presence of triggers from innocuous cutaneous and intraoral stimulation of the skin on the same side of the pain, such as light touch, chewing, wind blowing on the face, cold temperature, brushing teeth and brushing hair. Interestingly, alcohol seemed not to be a frequent trigger in SUNCT and SUNA, unlike what happened in some of the other trigeminal autonomic cephalalgias, especially cluster headache. We also noticed in our cohort that restlessness, which is a typical behavior of some of the other TACs, is not frequently associated with the painful attacks in SUNCT and SUNA. Indeed, the majority of patients prefer to stay still during an attack. We also did not find any clear-cut circadian or circannual periodicity of the occurrence of the attacks in SUNCT and SUNA. We've also confirmed in our study that SUNCT and SUNA seem to follow a chronic pattern, unlike some of the other TACs, especially cluster headache. The clinical phenotype of SUNCT and SUNA, as we've seen before, is quite complex, and it overlaps with the trigeminal autonomic cephalalgias one and the trigeminal neuralgia on the other end of the spectrum. For this reason, the differential diagnosis can be quite broad, and it's important for the headache specialist to be aware of the conditions that can mimic SUNCT and SUNA in clinical practice. Now, SUNCT and SUNA are largely considered idiopathic disorders. In view of the paroxysmal occurrence of their short-lasting unilateral headache attacks, with also frequent facial radiation and the typical associated facial autonomic symptoms, SUNCT and SUNA should be put in differential diagnosis with certainly the other TACs, as well as primary stabbing headache and some of the cranial neuralgias, especially trigeminal neuralgia. The high frequency of the daily attacks, along with their short duration, the stabbing, electroshock-like and burning characters of the pain, the presence of cutaneous triggers, the infrequent associated restlessness during an attack, and the lack of clear-cut attacks rhythmicity makes the diagnosis, the differential diagnosis with the other TACs generally straightforward. If any doubts persist, then an indomethacin trial will always exclude, a negative indomethacin trial will always exclude indomethacin responsive headaches such as hemicrania continua or paroxysmal hemicrania. The differential diagnosis between SUNCT and SUNA and primary stabbing headache is generally easy, given that the latter condition is not normally associated with cranial autonomic features and that the pain territories in primary stabbing headache normally vary within the trigeminal distribution, which is an unusual pattern in SUNCT and SUNA. More difficult can be the differential diagnosis with trigeminal neuralgia, given the broad clinical overlap between TN, SUNCT and SUNA. SUNCT and SUNA pain normally occurs more frequently over the first division of the trigeminal nerve, unlike trigeminal neuralgia pain, which is more often centered over the V2, V3 territories. Furthermore, the attacks of SUNCT and SUNA last generally longer than the ones of trigeminal neuralgia, and of course, trigeminal neuralgia is not thought to be associated with ipsilateral cranial autonomic features. In both conditions, the attacks can be triggered by cutaneous stimulation, but in SUNCT and SUNA, there is normally an absence of a refractory period, which means that the attacks can be triggered one after the other without any break in between, which is what normally happens in trigeminal neuralgia. SUNCT and SUNA are generally considered idiopathic primary headache disorders. However, there are certain brain pathologies that can produce a phenotype that mimics SUNCT and SUNA. More frequently, pathologies of the posterior fossa, such as arteriovenous malformation, aneurysms, inflammatory plaques, and strokes of the brainstem, have been shown to be able to produce a SUNCT-SUNA-like phenotype. Interestingly, adenoma of the pituitary gland, either secreting like prolactinomas or non-secreting, have been able to produce a SUNCT-SUNA phenotype in certain case series. And quite recently, it has been shown that a high proportion of patients with SUNCT and SUNA may display a trigeminal neurovascular conflict on the same side of the pain in MRI scan with trigeminal sequences. The treatment of SUNCT and SUNA is historically considered quite challenging in view of the lack of robust clinical trials. The core of the treatment includes oral long-term preventive treatments and transitional parenteral treatments. The concept of abortive treatment in SUNCT and SUNA is rather unhelpful in view of the short duration of their attacks. It is important to remember that SUNCT and SUNA tend not to respond to treatments otherwise effective in the other TACs, such as sumatriptan injection, oxygen, indomethacin, verapamil, oral steroids, and intravenous dihydroergotamine. Conversely, they tend to respond to treatments effective in cranial neuralgias, such as the sodium channel blockers. The available evidence show that lamotrigine is the preventive treatment of choice in SUNCT and SUNA, followed by topiramate, gabapentin, carbamazepine, and probably oxcarbazepine. Transitional treatments are sometimes used in case of SUNCT status, where the SUNCT attacks occur relentlessly without any breaks, often causing severe degree of disability by preventing patients to eat and drink properly. To try and break this pain cycle, intravenous lidocaine can be sometimes administered as an inpatient with ECG monitored, and is considered one of the best treatment in these cases, although the duration of the beneficial effect is normally limited to the infusion time and sometimes for a few weeks later. Greater occipital nerve blocks injected, performed on the side of the pain, seems to be effective in a proportion of patients. The response rate in SUNCT and SUNA is considered around 50%, with the duration of the benefits ranging between 1 to 6 weeks. Recent evidence has also suggested that sphenopalatin ganglion pulse radiofrequency treatment could be an effective non-pharmacological, slightly more invasive option in patients with SUNCT and SUNA, with a duration of the effect lasting up to 10 months. Unfortunately, a minority of patients with chronic SUNCT and SUNA fail to respond to the established above-mentioned treatments, and for this reason they are considered refractory. For these patients, neuromodulation approaches could be justified given the high level of disability. Occipital nerve stimulation has been considered the treatment of choice for some years, with a response rate of around 77% in some prospective open-label studies. Ventral tegmental area deep brain stimulation has also been shown to be very effective in about 80% of patients, although this approach is considered more invasive than ONS, hence is normally kept only for patients that are occipital nerve stimulation non-responders. Promising initial evidence has also shown that the efficacy of trigeminal microvascular decompression for patients in whom the MRI scans of the trigeminal nerves show significant ipsilateral trigeminal neurovascular conflict. Current open-label evidence show that the response rate of this surgical operation is about 67%. However, larger studies with longer follow-ups are needed to confirm these initial findings. In conclusion, it seems that SUNCT and SUNA belongs to the same clinical entity, which overlaps between the trigeminal autonomic cephalalgias and trigeminal neuralgia. If suspected in clinic, a patient with SUNCT and SUNA should undergo an MRI scan of the brain with pituitary fossa sequences and trigeminal nerve sequences to rule out a pituitary adenoma or a trigeminal neurovascular conflict. In terms of treatment, lamotrigine seems to be the drug of choice, followed by topiramate, carbamazepine, oxcarbazepine, and perhaps gabapentin. Transitional treatment can be quite useful in SUNCT and SUNA, for example, intravenous lidocaine in patients that have what we call a SUNCT status, whereby they can't eat, drink because of the relentless headache attacks. And in a proportion of patients, also greater occipital nerve block could be considered an effective treatment. For the very difficult to treat refractory chronic forms of SUNCT and SUNA, neuromodulation could be considered an effective option, especially occipital nerve stimulation and deep brain stimulation. And there is initial evidence suggesting that trigeminal microvascular decompression in those patients who display a neurovascular conflict on the MRI scan could be a potentially effective treatment, but further studies need to confirm this initial finding. In general, the general feeling, looking at the overlapping phenotype between SUNCT and SUNA and trigeminal neuralgia, but also the overlapping treatment response and neuroimaging finding, suggest that the three conditions may constitute a spectrum of disorders rather than different entities. And this fascinating topic should be the subject of future research in the headache community. Thank you.